Hello, everyone. My name is Lyndsay Massey. I'm a third-year resident at Stony Brook University Hospital in Stony Brook, New York. We are very excited to share the beginnings of this project with you. In this project, we're asking, can we, as emergency medicine providers, detect regional wall motion abnormalities on point-of-care ultrasound during acute coronary syndrome? We initially came up with this idea because we would often get these patients in the ED, the ones that were very concerned for ACS, and we want them to go to the cath lab. So we'd call up our cardiology colleagues, and they would inevitably ask, what's the EKG and what's the troponin? As we all know, these are imperfect tests and do not catch all cases of ACS. So if these were negative, whether our patients would go to the cath lab was entirely dependent on our persuasion skills that day and the mood of our cardiology colleagues. So we wanted to find some more objective data. In our search, we came across this amazing article in ACEP Now by Drs. Johnson, Lavallo, Frankel, and Nogdev on the utility of detecting regional wall motion abnormalities on bedside ultrasound. I was able to speak to a couple of the authors of this paper, Drs. Frankel and Nogdev, and they were both very helpful when we were beginning this project, so a big shout out to them. In their article, they note that trained sonographers may be able to detect regional wall motion abnormalities and identify patients with significant coronary artery occlusion that's not evident on the EKG or the initial cardiac biomarkers. But in their paper, they also emphasize that in the hands of a novice sonographer, these findings should not be used to make clinical decisions. So then we wanted to know, could we, as emergency medicine physicians, detect these regional wall motion abnormalities with any accuracy with just a minimum amount of training? So this is what we did. Any of our ED physicians with a minimum of 25 supervised POCUS echoes and a 30-minute training session could perform echoes on patients with a high suspicion for ACS. At the time of the echo, the ED physician recorded whether or not they saw the regional wall motion abnormalities on the echo and in what territory they were seen. POCUS echo was then compared to cardiac cath and or formal echo as the gold standard. The physician was not blinded to the EKG. On our analysis of the results, true positives were only counted if the physician correctly identified that there was a regional wall motion abnormality and attributed it to the correct territory. False positives were counted if the physician recorded a regional wall motion abnormality when there was not, or they correctly reported that there was a regional wall motion abnormality, but attributed it to the wrong territory. Here's what we found. For all levels of training, the accuracy ranged from 80 to 100% and increased with level of training, and the sensitivity ranged from 88.9% to 100%. PGY2s and PGY3s had a specificity of 0%. We think this is because of our small sample size. Each of these groups had no true negatives, and each had one false positive, making their specificity 0%. The fellows had a specificity of 60%. This was based on 3 true negatives and 2 false positives. The attendings had 1 true negative and no false positives. We hope that as we do more echoes, we'll be able to find more true negatives and increase our specificity. We also wanted to look at our accuracy, sensitivity, and specificity for detecting regional wall motion abnormalities in STEMI versus in STEMI. The accuracy was 87.5% and 76.9% respectively. The sensitivity was 95.5% and 85.7% respectively. And the specificity was 0% and 66.7% respectively. Again, for the STEMI, the 0% specificity was due to the fact that there were no true negatives and 2 false positives. On these 2 false positives, the ED provider accurately saw that there was a regional wall motion abnormality, but attributed it to the wrong territory. So here are the raw numbers. So again, small sample size. The limitations of this study are, again, our small sample size, which we are actively working on improving, and the fact that the physician was not blinded to the EKG. Since they are not blinded, this could introduce bias, but also it's more true to life. So that is why we decided not to blind the physician to the EKG. So in conclusion, even with minimal training, ED physicians are able to recognize with decent accuracy and sensitivity regional wall motion abnormalities, but specificity leaves something to be desired. We're excited to continue this project, and we hope that as we get more echoes, we will continue to have high accuracy and sensitivity, and our specificity will improve. Thank you.